Good evening, everybody. Welcome to today's Zooming In webinar. We have 26 people in the audience already. Some people are still coming in, but let's start already. My name is Max Wolf. I'm a clinical psychologist and addiction researcher. I'm involved in the research and knowledge exchange department at the Mind Foundation. This is already the 5th episode of the Zooming In webinar series within the Mind Academy. Each Zooming In episode I have an in-depth conversation with a researcher or clinician involved in psychedelic therapy or neighboring disciplines. And at this point, it's always time for a disclaimer. When we talk about psychedelic therapy here, we always refer to legal treatments that take place in a professional clinical setting under highly controlled circumstances. What we talk about here does not necessarily apply to illegal underground therapies or unsupervised self-medication with psychedelics, both of which we do not endorse. Now, our guest for today is Dr. Roberta Murphy, clinician, who is joining us today from London, and she will introduce herself in a few moments. Roberta and I will have our conversation for about 1 hour, and then we will have 30 minutes of Q&A. You can already start posting your questions while Roberta and I are still in conversation. Please do not wait with posting your questions until we finish. And please use the Q&A button to post your questions. Do not use the chat for questions to Roberta and me. And you can use the chat for technical questions, for all kinds of comments, and for chatting, of course. Operating in the background, we have Andy Meyer. Andy is our technical moderator today. He will also post links to interesting stuff that's related to what Roberta and I will be talking about, interesting papers, related events, etc. So please leave the chat open so you don't miss any of that. Now, it's my pleasure to introduce Dr. Roberta Murphy. Roberta, happy to have you on the show.
Yeah, great to be here.
Roberta, could you say a few words about who you are and what you do?
Yeah, so I guess I'm a psychiatrist by background, and I suppose the reason that you've invited me in today is that I spent the last 2 years working in Imperial with what is now the Center for Psychedelic Research. And we were working on psychedelic-assisted, which was a phase 2 trial comparing psilocybin or magic mushrooms to antidepressants. And we were looking at people with kind of moderate to severe depression. And I was working both as a doctor and kind of a therapeutic guide. And I suppose one thing that we're talking about today is because around the topic of trust is the fact that I was sort of leading the kind of screening and recruitment and thinking about the kinds of people that we included in the trial.
Right, yeah. I'm looking forward to chatting to you about that. Maybe to start, or to give our audience an idea about this study, psychedelic-2 study, could you give us a brief overview of the study? Like maybe first of all, what was the study's objective?
Yeah, so it was a mechanistic trial. So I suppose the idea was that we were, I suppose, comparing kind of how well psilocybin worked compared to escitalopram, which is an SSRI antidepressant, but also specifically looking at how they worked differently. So I suppose obviously, antidepressants are an established treatment. So I suppose just trying to see, well, maybe both work, but maybe they do it in different ways. So it was sort of looking at both brain imaging and so MRI changes, which I don't know much about and won't kind of attempt to talk about, but also their depression scores. So looking at change in depression scores by the end.
Okay, so you're comparing psilocybin against kind of a psychiatric standard treatment.
Exactly.
For depression. Okay, so can you tell us how many patients you treat or were treated in general in this trial?
So in total, I think it was 59, but I think the idea was that we'd have 60 and then it would be 30 versus 30. So 30 people on the psilocybin versus 30 people on the SSRI.
All right. So it's quite a large study compared to the initial psychedelic-1 study that had only, 16 maybe, or?
Yeah. I mean, phase 1 trials, I think, are always quite small. I mean, it is a large study, but then compared to, I guess, typical pharmaceutical studies, it is quite small. I think what we might always forget is how expensive trials are. And so, that was kind of, I suppose, what we could manage with the economic considerations. But, I think if you look at typical antidepressant studies, they often have hundreds of people in it,
Yeah. Okay, so 30 versus 30. And as far as I know, the trial has already been concluded, right? You're not treating anymore.
Yeah. So we finished it kind of actually just as coronavirus hit, basically, was the end. Yeah. So more.
Okay. And I mean, I haven't seen any published results yet. I'm not sure if you're allowed to talk about that, but can you say a few words about good or bad or? Okay.
Yeah, it's going to be published soon in the New England Journal of Medicine. And so, I mean, actually, I'm not sure what soon is. I don't know how slow these things take, but the paper is written and I think submitted. But I think I can't give away specific results, but I can definitely say that they look good. That psilocybin has done well.
Right. Okay. Yeah. I wasn't expecting anything very different from that, but I'm certainly looking forward to see the precise results.
Absolutely.
Now,
yeah.
Roberta, to give us a bit more of an idea of how this treatment looks like from the patient's perspective, could you walk us through what the patient's experience is from enrollment of this study? Or
yeah, sure. So I guess I would say almost like a little bit part of the I suppose there's a screening process, which is sort of a phone call, 2 Skypes, and a face-to-face. And by the time people hit the end of that timeline, so the kind of face-to-face screening, at that point we generally, we're 99% sure that person is going to come in. And the only thing that might go against them would be, if their bloods came back as abnormal, which is really rare. So at that point, they meet their therapy guiding team and they kind of start to tell their story and to get to know them. And then we had a telephone call with them sort of a week before they came in. And that was to sort of, I suppose, tell them a little bit about how the process would go, think about things like music, food, all that kind of stuff. And then I suppose the actual structure of the trial was your sort of classic, I guess, preparation, dosing, integration. And there were 2 of those. So there was 2 sort of dosing sessions, and they were 3 weeks apart. So I guess, it's always a bit hard to follow, but basically preparation, dosing, integration, 3 weeks later, dosing, integration.
And as a patient, I receive either 2 times psilocybin or 2 times placebo.
So it actually, I'm not sure what I'm allowed to say about this, actually.
Okay, all right, okay.
But basically, yes, but actually, we'll just leave it at that.
Okay, yeah. But it's safe to say that half of the patient received a high dose of psilocybin.
Yes.
In at least one of the dosing sessions.
I mean, I think what I can say is that people received sort of 2 high doses, or they received, 2 extremely low doses that were basically equivalent to placebo.
Okay.
So
Got it. Okay.
And people who get the placebo, of course, are taking the antidepressant then.
Yeah. Okay. And so today's topic is role of trust in psychedelic therapy research. And you said patients only met, twice before the dosing session, their therapists?
So I think, I suppose typically, people would have had probably 3 to 4 points of contact. So I had a little bit of an advantage actually as a therapist in the trial, because I was also doing the screening calls. So I would often, have also had the screening calls and the other kind of preliminary calls. But for most people, they would have, I suppose, the initial screening face-to-face visit, and then 1 telephone call, and then 1 preparation session, and then it's go time. So it's quite a small lead up. Yeah.
How many, let's say, how many hours are that of contact prior to the dosing session, more or less?
5.
5 hours. Okay.
Yeah.
One could assume that's very short time to develop a therapeutic bond, I suppose.
Yeah. I think it probably, most of the time it was okay. But I think for some people it was definitely too short. And I think that we had to specifically include people who we thought could sort of build trust and feel safe with this very quickly, because of that being kind of our setup.
Yeah. I think we're going to have to go into that later, because that's really interesting. What does this mean what does this issue of trust mean for screening? What implications does it have?
Yeah.
But maybe before we do that, let's talk about the necessity of building trust. So, of course, trustful relationship is important in all psychotherapies, or in all interactions between clinicians and patients, regardless of psychotherapy or what kind of other medical treatment. But one could say, or my intuition is that it is perhaps especially important for psychedelic therapy. Would you agree with that?
I mean, I thought that was a really interesting question, actually, and I kind of was in two minds, because I guess one part of me thought, well, there is sort of this idea that the psilocybin is the therapist, right? I mean, and you're sort of just there, being a kind presence, and so I thought, well, you could almost argue in that sense that the therapist and the clinician is less important than in a normal therapeutic relationship. But then I also thought, there is something particularly, I suppose, extreme and deep and vulnerable about these states, and everything is amplified. So when there isn't trust, that is amplified also. So I guess I don't know the answer, but those were the kind of two things that I started thinking about,
Yeah, but the reason why I thought that is what you said, right? It's people become very context sensitive.
Yeah.
And in that situation, during the dosing session, probably a very significant proportion of the context is the relationship, the social relationship with the people who are present.
Yeah. I think it's a really interesting question. And actually, to be honest, it's something that I'm trying to write a paper on at the moment, is actually trying to see how much does it matter, and is this sort of idea of like therapeutic rapport, does that have a massive link to outcome, because I think it's something that we all presume is important, but I think it's also something really important to show, for sure, because of retreat centers and people who aren't trained and all this kind of stuff. I think of people to show that actually, it is really important that they have purpose, we're able to build that trust with people.
Yeah. So we really have to underscore that it's an intuition that we may have, but we don't have data on that, and it's not really very known. I should add at this point that 2 weeks ago I had a guest from Brazil here on the show, Fernanda Payano Fontes, who treated depressed patients in Brazil with ayahuasca. And apart from the fact that she's not a psychotherapist, but an electric engineer, they only saw patients on the day of the dosing session. They only met them then and did 20 minutes or something like that of preparation. And trust didn't really seem to be such a big issue in that context either. So we may be wrong about the role of trust.
I think it's really interesting. I mean, I suppose, I don't know if you just had people and you just did dosing sessions, would it be different? We also had a lot of integration sessions and, Skype calls in between. And so we were doing a mix, I guess, of psychedelic therapy, in itself, but also a little bit more talking therapy integration, and then the relationship plays in a bit more. But yeah, I intuitively think it's important, but maybe that's just my own narcissism as a therapist, I don't know.
Right, yeah. Probably not, but yeah. We should add at this point that there was really psychotherapy involved. So there was a model, a therapeutic model.
So I guess we use the model, which is a paper that we might discuss later, that Rosalind Watts had, she wrote, and it's around the kind of accepting, connecting embodiment, and so it's sort of a loose model. It's not psychodynamic, and it's not really working as much with sort of things like projections or relationships or, that kind of stuff. I think it's more of a humanistic, supportive model in I guess, supporting them on their journey. It's sort of...
Yeah, we will hear more about that paper towards the end. Now, so maybe to give us more of an idea of why trust could be important, or trust issues could be important in psychedelic therapy. What would you say? What could happen? What could go wrong if there is not sufficient trust between therapists or therapists and patients?
I mean, at a very I mean, I suppose sort of, there is kind of this idea of like that there is no wrong, I suppose, so this idea of like whatever comes up in the session is where you need to go, and this idea of kind of inner healing wisdom. So I suppose you can kind of look at it in two ways. Our research was very outcome driven, and it was looking at, has your depression improved at a 6-week mark? And, this is like a false cutoff, and, it is sort of problematic in lots of ways. But I think what we saw sometimes is that people who found it hard to feel safe, or to be kind of, to feel that they can trust us, that often they might have what you might call resisting. And so they sort of maybe resisted going into their own internal world, and they sort of projected outwards. And so what you might kind of see is sort of a lot of anger or feelings of rejection or paranoia, that kind of thing. And so things get sort of played out in the room rather than them maybe going in that more inner journey. And what I think we did kind of see is those kinds of people, often their depression scores hadn't changed by the end of the trial. Now, whether or not, if we had a really flexible model and we could have done much more therapy with them and many more sessions, I like to think of it maybe as a possibility of there just being short cases and long cases, that was just not the right model for them. But I guess that's the kind of thing you can experience.
Right. Yeah. So to give us a bit of more of an idea of what that looks like. So in this trial, you used for dosing sessions, I suppose you used the standard model where people listen to music and wear eye shades and are encouraged to go inside most of the time. And
what would often happen is that people either during or afterwards would report that they didn't have an experience, that they didn't see anything or they didn't feel anything. And we had the doubly complicated situation of not actually knowing if they got psilocybin. And I think if we had known for sure, we've just given them, 25 milligrams of psilocybin, then we could have, I think, more confidently worked with situations like that. But sometimes we didn't know. Is it because they've been given this sort of tiny, basically placebo dose, or is it because they're resisting, which was sort of a really added difficulty for us in the trial. But what it would look like is that they weren't having much of an experience. And I think I can speak about 2 of the cases. We definitely thought they'd been given a low dose. We weren't necessarily even suspicious. And some of the cases we could tell, and they were so the 2 people who thought they'd been given low doses reacted with quite a lot of anger, that they were, extremely disappointed that we had let them down, that we'd given them this low dose, and there was a lot of despair and sadness. And it was quite a heavy atmosphere in the room. And then there were some other cases that were perhaps a bit more avoidant and closed down. And so they didn't want any contact from us, or they didn't want us to hold their hand. But there was a feeling of there being maybe still some kind of anger in between us and them.
So we should add at this point that this study that we're talking about is a bit of an outlier compared to other studies. Due to the design, there's no crossover, right? So in most current time psilocybin studies, patients who receive a placebo will eventually get the high dose later, and this was not the case in this study. So people could get really disappointed when they didn't, or when they thought they hadn't received a full dose of psilocybin.
Yeah, and also when they genuinely didn't receive it. I mean, it was incredibly difficult for both the participants and for the team, I think, to work in that context.
Yeah. Right, yeah.
I would have prayed for a crossover.
Yeah. And were there any patients with trust issues, or where trust became an issue during dosing sessions, where you were sure that they had received high dose of psilocybin?
Yeah. There was, somebody who became, to be honest, not much, I would say. I think that sort of what occasionally people would report retrospectively, that they had started to feel a bit unsure perhaps of our intentions, or maybe just that they were feeling a bit ashamed or worrying about how we were perceiving them. There was only one person who really sort of became mildly paranoid, I would say. in a kind of a slightly confused, this sort of typical, I've lost my mind and I'm never going to come back to my normal mind again. But mainly it was what I kind of described to you, sort of a real resistance, or else kind of an anger, kind of a sort of a feeling that it became a conflict.
All right. Okay. Well, thank you for those illuminating examples. Now, we should say that you did quite an effort to only include people who are unlikely to have severe trust issues. Could you tell us a bit more about the screening process or patient selection?
Yeah.
How do you make sure that?
Yeah, I think it's something that we thought about a lot. I think if you wanted to make a purely sort of scientific argument, you could say that you should just include anybody and everybody and just sort of see what happens. But I think, you have an ethical duty to people not to bring them into something that will be too difficult or too challenging. And the fact that we only had 6 weeks with people and not kind of any follow-on care meant that we had to be quite sure that we would, be able to contain people, that it wouldn't be too traumatizing, that in a way it would be, I guess, kind of wrapped up nicely by the end, and that was quite a specific kind of cohort of people. I guess thinking specifically about trust, we would think about, I started to include more and more questions in the kinds of screening stuff. So thinking about who their relationships were in their life and what they're like, their experience of therapy previously. So, I guess people who have no friends or no partners and get fired from jobs and conflict with colleagues and all my therapists have been terrible, or, this kind of thing. Or somebody who never has felt safe to do therapy, or, so these kinds of things that they start you thinking. And also, of course, you're attuned to your own experience of what it's like to be with the person. And how they're reacting to you and your instinctive feelings and all that kind of stuff.
So is it really actually possible to completely formalize that process of screening, or is it more kind of a gut feeling thing, or a decision that this person doing the screening has to perform?
I think that I think what happens with experience is that you're able to put words to your gut feeling. I think that, often at the beginning, when you're quite new, you have a feeling about somebody, but you don't really quite know what it is or why it is or how to tell your colleague about it. And so we were quite respectful of each other's gut feelings. And I think at the end of the day, you also have to keep in mind that it is also your particular chemistry with somebody. So you and I might have a bad feeling about different people, that they're bringing something out in us. And that's okay. It's okay to recognize your own limitations of who you can work with. So I think what was good was to try and bring it to be like a multidisciplinary decision. So to kind of almost have as many people have contact with that person as possible before they came into the study. So I think that's kind of useful.
So it's kind of a committee approach to screening, so to say.
Yeah.
And just to give us an idea, how many patients did you have to screen in order to include one, more or less?
So I think I calculated at some point that we had about a 5% inclusion rate. There were lots of reasons why we didn't include. Some people just didn't necessarily, have the right diagnosis, or they had a family history or personal history of psychosis, that kind of stuff. Some people just weren't depressed enough. Quite a significant amount of people were below our cutoff. And then I guess down the line, and physical health or, this kind of stuff, there were just people who you just felt like it's not going to work. It's too much trauma, or it's too complex, or the relationship's going to be too complex, that kind of thing.
Okay. So, is this really then, can we really say that this is a study of treatment-resistant or of depression, or can we say this is a study of like easy patients with depression?
I think that we can definitely say it's a study of easy patients with depression. And, I think that's okay. I think it's, you have to think about, the kinds of people, if you're working in a therapy department, if you are giving somebody 6 weeks of short-term psychodynamic therapy, there is a specific kind of patient that is suitable for that. and it's sort of not really fair to bring somebody who's not in. And so I think it's okay to give people who are really going to be able to use the opportunity to see changes by the end, to come in. And also, I think there's something about people put so much hope into this treatment. I think it was really, really disappointing for people to come in and to not be able to go in and through and to kind of come out the other end, with nothing changed. That was incredibly difficult, both for us and for them. So, I would stand by that, but I think that the results need to have that, when people look at the results, they need to keep that in mind. These aren't a random 60 people that we picked up off the street,
Yeah. So people are already quite selected when coming into the study. And then were there cases where during preparation, only during preparation, you notice that there may be trust issues or people have more difficulty building trust?
Yeah, I mean, there was never anybody that we said we can't proceed. I think we were, we kind of, by the time we brought anybody in, we were pretty sure about them. But there were definitely people that we kind of, during the preparation, we had, places that we made our clinical notes and, kind of recordings, we used to record things. And you can hear the therapist kind of often saying, I'm not sure how it's going to go tomorrow.
What would be a typical kind of behavior that would occasion these kinds of thoughts or considerations?
I think there's something about people's ability to connect with you, actually. So I think when you have a feeling about somebody that they're kind of avoiding that vulnerability and that intimacy with you, and what that looks like is I guess quite, hard to explain. But I think, for example, if you were to ask somebody, I think what I think was often kind of a good sort of sign was when you try to ask someone to speak about their feelings about you, about how they might be worried about what you're thinking or how they might, this kind of thing. If they can't go there, I think that's often a sign that there's sort of a real fear, actually, of any connection or any vulnerability, that they don't almost want to kind of acknowledge you as a person with your own thoughts and feelings and, this kind of thing.
Right. So would you say that explicitly addressing the therapeutic relationship is essential in?
Yeah, and we would always have done a part of our preparation to sort of, I think about, different, I guess, anxieties they might have about us and, things about how, they might be worried about entertaining us or needing to impress us with, where they're going or that we're judging them, things like feeling angry towards us, feeling a lot of shame, worrying about us, needing to take care of us, all of that kind of stuff. And how they might find it asking us for help. Is that something that you find hard to do? Are you the kind of person who will sort of lie there kind of wanting someone to come but not really actually being able to say it? All that kind of stuff I think is really important.
Right. Yeah. So another thing that is often talked about, we also talked about it with our study team in the study that we're currently preparing to do in Germany. It's also going to be a psilocybin for depression study. We spent quite a lot of time talking about boundary agreements.
Yeah.
Could you say a bit how or what kind of boundary agreements were?
Yeah, we didn't have an explicit kind of written contract, which I know some sort of psychedelic therapists do. I guess there was sort of, an idea of like everything is welcome. There's nothing that is not welcome in the room. But nothing, there are certain things that won't be acted on. So I suppose in particular, we would talk about anger. So, aggression and anger is fine, but not obviously acted out. So, you can't hit us, and of course we won't hit you, which is a given, I think. But
this was told everyone. So this was explicitly agreed on with everyone.
So I guess there's certain things that people are, that are, socially seen as a bit unacceptable or shameful. So, things like sex and anger are two kind of big ones. And so we would say, we would often tell a story about somebody who had a sexual experience and how he was so ashamed of it that he completely went into himself and and actually that, that it is okay to have that kind of experience, to have this maybe all body mystical thing, but of course that we would mind the boundaries, that we would not act on it, that that they would be safe, but that it was okay for them to go into that if that was what they felt called to do.
Right. Okay. And so a related topic is the topic of therapeutic touch. I suppose therapeutic touch is important in psychedelic therapy. Holding the hand is probably always done or done in each study that I've read about. This has been allowed. We talked about what are places in the body that are okay to touch for therapists. So
Yeah.
I think we agreed in the end the arm up to the shoulder is safe territory, and everything else is out of bounds.
Yeah.
How was it? Did you have a similar kind of rule, or?
I think it's really interesting because I think in a way there's all these sort of boundaries that people would normally never cross. You don't touch anybody in normal therapy, and then I guess we're all sort of finding our feet. I mean, a lot of my own personal work and some of the people who've trained me are holotropic breathwork workers, and so it's very bodily and very somatic, and there's nowhere that you cannot touch really. So we had a similar role of kind of nothing below the shoulder, but then I guess we were a little bit open to body work, but none of us, I think, felt completely confident to do it. But I suppose the idea is that probably you would, if you were going to touch a chest, that you would put a pillow in between, that kind of thing. But yeah, in general, we would hold the hands, put a hand on the shoulder, and we wouldn't really touch anywhere else in the body.
Right.
And I think when if you're not completely confident or you're not, completely trained in that, it's always better to do a little bit less than more, I think.
Yeah, sure. Yeah. So what else would you say is important for therapists to do during preparatory sessions to ensure a strong enough therapeutic bond, feelings of trust and safety?
I think this is something, so Roz, wrote this really amazing therapeutic protocol. And in that, it was really, I guess, very sensitively and thoughtfully written, and sort of trying to really address sort of, a lot of the kinds of issues that might come up. So it was really, and I think in that way, that was quite containing for people to sort of feel like, okay, they've really thought about all of my worst fears, or they've really, and also we use a lot of self-disclosure. And I think that is a kind of a fast track way to build trust when you're, only have 5 hours. So, we would talk about our own experiences. We would talk about our own difficulties. I mean, without, taking over the whole thing. But I think there is something important about knowing that the person with you knows what it's like, to lie there, going through something that they feel really ashamed of, and to have someone come up and hold your hand, that they've been there, and they've worried about what the person looking at them was thinking, or were they going to wet themselves, or were they lost, have I lost my mind, all this kind of stuff. And I think there was something quite reassuring about that.
So we also discussed this in our study team. So how do we talk about the obvious elephant in the room of therapists' own psychedelic experiences? I assume that's important for, if I was a patient in such a trial, I would probably want to know if my therapist knows the territory, right?
Of course, yeah. I think it's a personal decision. We spoke about it a lot as a team. I mean, different people in the psychedelic community have different ideas about this. I'm always quite open about things. I have had, experiences that were completely illegal. I've drank ayahuasca in countries it was legal. I've taken, truffles, in the Netherlands, all these kinds of things. And, also, a lot of my most important psychedelic experiences were breathwork sessions. So I think you would be doing, personally, this is my own opinion, that you're doing a disservice to yourself and the therapeutic relationship and the person you're with by trying to hide that. I think you can find a way that is safe to talk about it.
So did patients address it by themselves usually? This
I
question?
opened the floor to them. So I would say, I'm sure you're probably curious as to whether it's my own experience. Because, people don't want to ask, you're like, a doctor, and I mean, I am a doctor. I don't know why I did that in comments, but that they don't want to say it to you, and they don't know maybe that that there are ways to do this legally, and so I would always say you're welcome to ask me any questions, and that includes if you want to ask me about any of my own experiences.
Yeah. So I suppose that's one major thing you can do in order to improve trust, or to build trust.
I think it's a fast way to do it. Yeah.
Yeah. What other suggestions do you have? Do you have any other things therapists shouldn't forget to do, or not to do?
I suppose I think that the whole model of the inner healing mechanism is really important. And maybe this is my own thing because I'm always worried about doing things right and all this, but I think a lot of people have that. And so I think just unfolding the whole thing is you'll go where you need to go, and to be kind to wherever you need to go. And really, I think trying to really educate the person in that kind of model is really important. Because I think if people have a feeling of that whatever happens, the person with me is okay. They don't have any expectations. They're not looking for this fantastic psychedelic, cosmic journey. And again, I would use things like self-disclosure. Talking about times that I've resisted, or that I haven't felt much, or what I might have learned from that, and and I think it's all. For me, I think it's all ultimately a lesson in self-compassion and self-acceptance.
Yeah.
And I think sort of modeling that is really useful.
I remember when in my conversation with Leo Roseman, that was last month, I think, we talked a bit about the prospect of doing group therapies with psychedelics. Do you think there is some of these things could be easier to discuss between patients than between therapists and patients?
Yeah, I think definitely. I think what's such an issue for so many people is just a lack of community, disconnection, isolated, feeling on their own with things. And this is something that Roz actually is really interested in, and she's an amazing thing. She's always trying to think of ways, I guess, to build community, and she set up sort of a online integration group, and all this kind of stuff to try and give people places to share and to connect. And I think there is something, I think no matter what, no matter how down to earth and whatever you try and be, there's always a kind of a difference in a relationship between your therapist or guide and, the patient versus two people together. And I think there is an openness and a vulnerability, and also it's a bit more like a real relationship, it's more like a real friendship. And also I suppose they don't have to, they can give each other hugs. I mean, we hugged our participants, but I suppose, they can kind of hold each other in a way that we can't.
Mm-hmm. Yeah. When I'm thinking about the prospect of group therapies, I like to think of it as a process where patients who are further in the therapy can take care of newcomers, and where you can have this kind of exchange in the sense of, I've been through this already, trust me, So I think that could be a great resource to use in future psychedelic therapies.
I mean, I know in my experience of being in ayahuasca circles, there was sort of a feeling of sort of the beginning of the journey being sort of much more in and doing your own work, but then at a certain period, I guess the circle will close, and it would become a much more social thing. And actually what I noticed myself, is that some of my maybe, relational difficulties, maybe my social anxiety, or, whatever, that I would be able to work on that in a different way. So I think it's really important actually to have a mixture of both, because we're not just isolated people looking inwards all day. We are social creatures. We're within communities.
Yeah, right. So I'd like to change the topic a little bit. So far we've talked about trust in a kind of standard psychedelic therapy research, where it's little preparation, before dosing sessions. We've heard that a lot of patients have to be excluded from that. And we've talked about trust as a kind of a determinant of treatment success. And we have not covered trust or the ability to trust as a treatment target. And I think that's probably also something we should try to discuss. So we know that long-term responses to psychedelic treatments appear to depend on somewhat on the quality of the psychedelic experience that people have under the acute influence of the drug during dosing sessions. Yeah. And this makes me think that perhaps profound experiences of trust or safety or being protected by another person or psychedelic experiences that involve these kinds of feelings might have a very positive impact on people's ability to trust. So do you think psychedelic interventions, perhaps with more thorough preparation, could help patients who really, or whose main issue, or who have a big issue with trust, or who don't trust easily?
Yeah, I mean, I definitely think that's something to think about. I do think there is something about, I think a lot of people would talk about this idea of feeling almost like there is this kind of guiding presence in psychedelic journeys. And in a way, I think that there is sort of, and whether or not you call that, Mother Ayahuasca or God, or just, some like inner voice that you develop, you can think of it as you wish. But I think what it gives you is sort of almost like a reparenting sort of ability and kind of experience. So I guess in more typical therapeutic language, it gives you a good object. And I think in a way that's often what a really good therapist does, that they are somebody who is kind and accepting and who is able to, be there with you in your pain and your trauma and your shame. And I think sort of it's that amplified, I guess. So yeah, I absolutely think that kind of thing can help.
From your perspective, would you say it's a common experience that people actually had in the Psilodep-2 trial? Did people in integration sessions address topics of trust or topics of the therapeutic, or did they mention that the experience involved thoughts about or experiences of connection to the therapists?
Yeah, I mean, a lot of people would talk about it really being one of their first experiences of that, of feeling accepted or even loved, and sometimes actually, that was almost like, I wouldn't want to say it's problematic, but what we did see actually was often we would end up being quite idealized. I guess we would often be idealized by those who got the psychedelics and denigrated by those who didn't. But we would sort of be idealized, and actually we had probably, I would say, a disproportionate amount of kind of maybe erotic transference of people sort of feeling a bit like in love with their therapist. But I think for a lot of people it was, a real kind of, first experience of feeling accepted and feeling that they could show their full self to somebody and that it would be okay. Right. And, I don't think you necessarily need to take psychedelics to get that. But I do think that is something that people speak about.
Yeah. So if we're talking about perhaps future treatment settings where it will be possible to see patients more often before dosing sessions, to prepare them more thoroughly, to build a therapeutic bond more, just more strongly, taking more time and resources for that. What would you say? What would a treatment like that look like for the typical diagnostic groups of people who have paranoid, let's not say paranoid, but mistrust as a typical component of their psychopathology?
I mean, I have to say I really don't know. And I suppose that's such a broad spectrum of people. And I think that I think that's a really interesting question. And I do kind of, something that I'm interested in thinking about is, can we sort of, as I said, my experience was that people would often resist and not go there, or they'd be able to really go in and they would, often enter this amazing psychedelic universe. But I suppose what I'm interested in is maybe thinking about, can you sort of tell when people are at that point? And can therapists tell when people are at that point? And I don't think that we had the right sort of questionnaires or surveys in our previous trial to ask that question, but it certainly is something that I would like to think about in future trials.
Could you elaborate a bit on that that point that you would like to, or that you think is important to recognize, or perhaps even to measure? Would you characterize that point a bit more?
I guess there's something about, there's something about this idea of like that you're sort of unpeeling an onion, and I think there's lots of, there's different arguments being made. So you could argue that you can just keep giving somebody, I don't know, like a psychedelic session, like once every 3 months, and they may be very resistant for the first 6, and then they'll finally, enter more of a psychedelic space, a stereotypically psychedelic space, I guess. Or you could say maybe these people just need to do a lot of normal therapy until they're at the point where they might be able to enter the psychedelic space. I don't know if I can say what exactly characterizes that, but there's something about, I think, people being aware of their own stuff, I guess, being able to sit with their own difficult feelings. So I think people who are, for example, very intellectualizers in their mind, people who are very anxious, if you see anxiety as a way of avoiding emotion, those kinds of people, I think, can be quite resistant. And the same as I think people who have a lot of mistrustful, maybe people more like, I don't like to use these kind of words, but personality disorders or that kind of stuff. Those, and I think that those kinds of people who maybe for lots of different reasons don't want to necessarily feel their own feelings or go into that inner world. But I guess to sort of, so I guess, but I don't know if it's possible. It may be just a very experienced therapist who intuitively has a guess,
The first thought that comes to my mind is as a very, probably very rough kind of rule of thumb is perhaps the extent to which a person or a patient is able to not talk for a bit in therapy and to endure silence, to let words rest. Could that be something?
Absolutely. Yeah, for sure. I think there is something about just being able to tolerate that anxiety.
Yeah. Right. So I know something about you that people don't in the audience. So you told me before our conversation here that don't worry, that you're trained in open dialogue therapy. And I had the thought that could be something that's probably relevant to your expertise as a psychedelic therapist and also to your experience of and competence in being a psychedelic therapist. So could you explain a bit to us what open dialogue is?
Yeah, sure. So open dialogue is a particular psychiatric model that they use in Lapland. And I think that they had really, it's quite an isolated kind of rural community, and they had really high levels of psychiatric difficulties, suicide, psychosis, or quite severe difficulties. And somebody just came in and they just decided to start their own quite unique psychiatric model. And how it works is it's sort of, I think, most similar to a family therapy, in that you sort of use kind of people's networks. So for example, I'm in crisis, I ring up, and 2 therapists or 2 facilitators meet me and my network. And I guess what I think is really quite nice about it is, I think individual therapy is important too, but I think ultimately actually what often needs to change is how people are living in their worlds, how they're relating to people, and everybody is always part of a system, and their difficulties are often a manifestation of that. But what's quite nice about open dialogue, I think, is that it's a very, I think, open way of working.
And is it, just to ask a bit, so it's mainly directed at patients who suffer from psychosis, right?
It actually, so in that place particularly, it's for every single psychiatric diagnosis. I think why open dialogue is interesting and why it's sort of gotten a bit more maybe press in the UK is because it is sort of a therapeutic way that people do work with psychosis. And obviously, things like that are they don't really get any therapy here. It's very medication based. And so I think it's really novel for those particular kind of difficulties. And they have quite amazing results, actually.
Yeah. And so would you say that your experience in open dialogue informs your work as a psychedelic therapist? Or
yeah, I mean, I think there's a really nice idea of you as a therapist not being sort of a fixer or even an expert. And it's a very democratic way of working, and it's very patient-led. So it's really, I think, giving them autonomy. And I think that that's a really sort of nice way of working. And it's also quite open in a way that I think, and it's sort of quite open both in the way that the team works. So I'm actually working in an open dialogue team remotely at the moment. And there's something very kind and inclusive and open about both the way you work with your colleagues and with the patients. You bring much more of yourself, and it's much more open. So yeah, I think those two things are really important. Because I think, especially for me, coming from a background of being a doctor, there is a temptation to me to be drawn into wanting to fix and to, almost like a car mechanic going, at the trunk, So I think that was a good learning for me.
Right. Yeah. So is it true that what you just said made me think of something you said earlier, that self-disclosure in psychedelic therapy, or being more present or open also about yourself in therapy, is that something that's also plays a role in open dialogue?
Yeah, people would talk a lot about how they're feeling, I guess, listening to people's stories. They would tell stories about themselves. It's a much more democratic way of working. Whether or not that is better or worse, or, I suppose those aren't really good words to use. I don't know, but I think it's certainly something interesting and something that I'm interested in seeing and exploring.
Right, yeah. Yeah, I was thinking that before, that when you said that self-disclosure, at least in your personal approach to psychedelic therapy, self-disclosure is such an important thing. And when I think about how relationships outside of therapy, friendships develop, or romantic relationships develop, is usually is through self-disclosure, right? It's through that's how also kind of gradients or differences in what should I say, authority or therapist patient, how that can even out a little bit.
Yeah.
Perhaps that's something that seems to be important in psychedelic therapy, at least from your perspective.
I think so. I think if you're trying to do more traditional therapy and you're trying to bring out people's projections and then you're trying to be a bit more of a blank screen, and that's just a different way of working. But I think for something like this, where you're there to support somebody, and I do kind of think that the psilocybin is the ultimate therapist, and and people can heal themselves, and I think there's something really beautiful about that, in that we're here to support you and hold your hand, but you can do it on your own. And you can heal yourself. You know exactly what to do.
Those are some beautiful, I think, beautiful closing words almost. Although we're not quite finished yet. So there is one.
I'll keep saying that never got into it.
Yeah. So we still have a minute or two. So before we go to our Q&A. So there is one question, because we're in an educational format. I like to ask this every guest that I have here at the Zooming In webinars. And it's if there is any academic paper or any books that you can recommend that you would say that shaped your approach to psychedelics or psychedelic therapy, and that you like to recommend to our audience.
So I really recommend sort of I actually know it. I'm not even sure what the title of the papers are, but the two, if you look up Dr. Rosalind Watts, they're her two papers that she's first author on. And one is her qualitative study looking at people's experiences on psychedelics. And for me, I think I read a lot of papers with p-values and statistics, but it just like opened up the world, it gave it color and words. And then the follow-on is her therapeutic model that she wrote sort of based around kind of, I suppose, patients' experiences. And I think they're both really amazing papers. And I think, she's a wonderful clinician and follow her work.
Yeah. Fantastic choice. I really like those papers too. By the way, there is perhaps Andy, you could post a link to the Rosalind Watts YouTube talk at the Insight conference last year. She gave a really great talk on that topic, presenting her therapeutic model.
Yeah.
And I was also quite impressed by the first paper that you mentioned. Qualitative paper. I think qualitative work is undervalued. I think we need much more qualitative work.
It's amazing. You take a p-value and then it opens up into this whole world.
Yeah.
It's been really crazy for us seeing. Robin has written the paper about ours to see sort of all of this years and every patient just sort of whittled down into a table. It's it's important too, but it is just a different way of thinking about things.
Yeah. So please, everybody, have a look into those papers. And now I always feel like the conversation could go on for much longer, but I'm afraid our 60 minutes are over. It's time for a Q&A. Let's have a look at the question. Can you see the Q&A button down there, Roberta? You can.
Yeah, I can see it.
Open it and have a look at some questions. If you see one that you like, you can already pick one if you want.
Yeah, sure. I mean, there's only, how long do we have?
We have half an hour.
Okay, there's only 9, so we can probably get through them all.
Yeah, so you can talk a lot.
Yeah. So I think this question is, I don't know if everybody else can see it or not, but what about trusting the medicine or the therapy in general? Do you measure that as well? So yeah, I think that's actually really something that I meant to mention, so I'm glad you asked that. So I think when we talk about our prep, we talk about 3 aspects of trust, and just one of them is trust with us as the therapist or guide, and the other 2 are to trust in yourself. So I guess just to trust that that your mind will come back, that you are able to do this, that you can go in and through, and also to trust that this psilocybin will kind of take you where you need to go. And so, yeah, we don't measure it, although we do measure how prepared people feel. But yeah, I think that is a really important aspect. And we do a lot of work around, I guess, educating them around psilocybin and how it might work and different kinds of experiences. And this kind of inner healing kind of mechanism is something that we talk about a lot.
How do you, I believe, if I remember correctly, the paper where the therapeutic model is explained is that you use, you put quite a lot of effort in metaphors explaining this, this assumed or the idea that that there is a kind of a healing, an inner kind of this inner trust. How do you can you say a few words on how precisely or how more or less that's done with the patients?
Let's talk about this idea. I think that this is definitely, and I think what's helpful is that this has definitely been my experience with psychedelics, is that you go where you need to go. And I suppose this idea of like that whatever experience you have is okay. And that there's always something important that can be learned, and then we would talk about, I suppose, the spectrum of experiences that people can have, and that it can be the smallest experience that can make a big difference. It's not always the amazing quintessential ego dissolution technicolor thing that changes things. Sometimes a smaller experience is easier to take home. So I guess we kind of talk about that a lot. And I don't know if people, people nod along, but I think afterwards people always said like, oh yeah, I totally know what you mean now. But beforehand, it was a bit like asking people to have faith in something, but it's the same in a way. You're asking people to have faith in a medication or a therapy, or, you have to have some trust in the process. So yeah.
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 What's the role, by the way? What's the role of the second? So you mentioned that some people get, or people got either 2 times high dose. So how are second doses different from first doses?
I mean, that's a really interesting question. I don't know if anybody's looking at this, but I think somebody should think about, did we need it? I suppose. I think people did often get more. I think what you could see is maybe one might be a bit more about acceptance. So maybe a bit more about going into the trauma, into the pain. And the next thing could be a bit more about connection. So a bit more of a kind of mystical experience, going into kind of maybe what's meaningful for them, self-love. But there wasn't any clear pattern,
Mm-hmm.
And then, at the end, we weren't totally sure how we needed the 2 experiences,
Right. Yeah.
Yeah.
Actually, we're going to look into that in our study.
Okay. Yeah.
We're going to 2 versus 1 psilocybin. Yeah. There will be, in 5 years or so, we will know more about that.
Yeah. I mean, we definitely had people who had very significant experiences in their second time, the second dose. And I suppose there is something about, the first time you take psychedelics is like, quite a big thing. And so I think there's something about being a bit more confident in what you might be able to do. But they're also quite close together. They're probably too close together, I think. But yeah.
Okay. Do you see any other questions that you like?
This one I can answer very easily. Just asking about second-degree family members with psychosis, bipolar, or schizophrenia. For us, that was fine. So it was only first degree that we outruled. Could the selection of the participants have influenced that bias the outcome of the trial? Yeah, I would say, I would say yes, but I would also say that, the kinds of people that we included in the trial are the kinds of people who you would probably give psychedelic therapy to in real life. So I think most people who we turned away, in particular with, the 6-week kind of 2-dose model that we had, I don't think you would be safe to include those people anyway. So I think it is realistic, but yeah, but the same as, I think if you're even working the NHS doing normal therapy, you don't just kind of include anybody and everybody. People get assessed. Are they suitable for therapy? Are they psychologically minded? Are they able to have a relationship? All this kind of stuff. So I think that's realistic of any therapy department. And so I think, yes, it is biased, but it is also realistic. Is kind of, I suppose, where I would land with that. What are the most important qualities a therapist should embody to ingrain trust in the relationship? I think that's a really important question. I think that people doing their own work, I guess that's not a quality necessarily, but maybe self-awareness is a quality. So I think, you're always going to bring some of your own stuff into the room. And I think, everybody has their own motivation for working in mental health or in this kind of, and I think you just need to really think about that, because I think it's kind of fine when somebody is sort of, I suppose, I've just realized I'm sitting in the dark. I'm just going to turn the light on. Hold on. So I think when it's all going right and somebody's having an amazing mystical experience and they're so grateful to you for it, that's easy, but I think it's when, things are really challenging and people are resisting and they're angry with you and it's getting tricky, then I think that's when kind of really proper training is needed. And so I think, things that people need are self-awareness. I think sort of being able to be quite mindful. So I guess sort of being aware of yourself and also not necessarily being reactive. So I think to be calm. And I think experience often helps you to be calm. I think people who are, most therapists are empathic and kind and caring. I think that's sort of the kind of people who come to the work. And I think people who are both experienced in psychedelics, but also maybe just in more normal therapy is ideal, but not necessarily. But I think there's something about understanding the more relational aspects of therapy that is important, along with having psychedelic experiences. And I guess just to have like integrity, and also to be the kind of person who, maybe if you say the wrong thing, that you can own up and say, yeah, sorry, actually, that I shouldn't have said that, or this kind of thing. And so I think, yeah, that's just a few things off the top of my head. I don't know if you can think of
a lot of things.
Yeah, but I think most people I know, we have an insight trial for healthy volunteers, and we had loads of the psychedelic research group would go in, and they would, they weren't trained therapists, and but they were all great, and I think a lot of people in the world already embody a lot of those things,
Yeah. Would you say there are, apart from what we already talked about, would you say there are certain practices or kinds of trainings that people should or could undergo in order to become better psychedelic therapists?
Yeah, I mean, I personally always think if you're going to be a therapist, you need to do therapy. I think that there is a particular learning that you only really get from being on the other side and understanding how it is to be in such a vulnerable position, to really show things to somebody that you're ashamed or afraid, or I think there's something really important about that, and kind of understanding the ways that people can make you feel safe or unsafe, because a lot of it is quite subtle, and I do think there's a lot that you don't realize until you're on the other side. And then, I guess a lot of people are interested, in things like meditation or yoga, or, more kind of holistic things. And I think also people, to have, and it's obviously tricky, because psychedelics are illegal in most countries, but, and then you say, you need to have psychedelic experience, and, people find their ways. But, what we did for our Imperial Research Group is that we did the holotropic breathwork sessions. And to be honest, for me, I've learned more from my holotropic breathwork sessions than any psychedelic experience. But yeah.
This is actually a question by a dear colleague, Andrea Jung-Aberle. Would you recommend breathwork sessions as part of the therapist's training?
I really, really would. I mean, if you go for one, especially that has its kind of origins in the more kind of Groffian kind of side of stuff. I mean, my experience, we have, our supervisor was a breathwork therapist, and I did, our Imperial group was trained using breathwork. And I think it's a really beautiful way of working. And I think what's quite nice about that also is that when you do the breathwork sessions, the way that model works is that there's a sitter and a breather. And so everybody who goes there gets an opportunity to be both, the person on the floor and the person taking care of them. And so I think that, it's a really amazing thing to do as a team, or, something like that. I'd really recommend it.
Some people might say it's weird to do that with your work colleagues. What would you say to that?
I would say there's something about people who work in psychedelics who are a bit less boundaried. And right. we were like this happy family, and we knew each other inside out, and there wasn't anything held back. And maybe that was our personalities. And there are some advantages and disadvantages of that, it was an intense workplace, but it was amazing and beautiful. But it is vulnerable, but I think actually it's really nice to share those vulnerabilities with your colleagues. I think it's really special.
Good. Yeah, I'm gonna say that in our next group meeting. So could you say a bit more? How often did you, or was this breathwork? Was this something you did before you started working together as therapists, or was it a continuous thing that accompanied the trial? Or
so we did. But Roz basically organized sort of a training week, and she had I'm gonna say his name wrong. It's like Mark Alexar. He's a Spanish therapist, breathwork therapist, and I think he's previously worked with psychedelics. And he basically did our training, and the two kind of main kind of holotropic breathwork people came in, and actually completely free of charge, they facilitated a breathwork session for everybody on that. There was maybe 20 of us, I think, and a lot of those people ended up not working in the trial, in because we made it a more kind of fixed team than we imagined. But it was something really special actually about, and something very beautiful actually about everybody there sort of wanting to work in this way. And of course, everybody who works in mental health has their own kind of things that they're interested in. And there was something amazing about it. It was really, and people had really powerful experiences. There was something about that atmosphere. And then we did a few other times throughout the trial as a group, and we did a lot of that kind of work together. And I think it was really, really amazing. But there is, I guess, it is a little bit less boundaries. You don't normally, our supervisor would facilitate the breath work, and normally maybe your supervisor in work wouldn't give you therapy, but it worked for us.
Right. Great. Yeah, it's nice to hear. Here's another question from Anita Kazai. Is it not ethically condemnable to do a not crossover study and give this big trauma to people that they wait? Now the question is disappearing. No, there it is. Yeah. That they wait for a healing experience and then get nothing, just a placebo.
Yeah, I mean, I think there's definitely an argument for saying that. I think, unfortunately, if you really want to, I mean, first of all, everybody was completely aware that that was the case coming in. So we really hammered home that, that was an option, and we made sure that people were prepared for that. Still disappointing and devastating when it happens, no matter how much people expect it. But people definitely knew, and we didn't include people that we thought it might be too difficult for. And we, I think my understanding is that if you want to bring something to kind of a legal market, you have to do trials like that, where you don't have crossover and where mainstream thing is compared. So unfortunately, from my point of view as a clinician, as the one who had to sit in the room and give them the placebo and be there for the disappointment, it was awful. But I think it's a little bit of a bigger picture thing. And I think actually a lot of the people who came really believed in psychedelics and were really interested in it. And, I think they got actually something out of being part of it, out of being, that even though it was a really disappointing day for them, and that, that they were sort of helping a lot of other people just by their presence.
Oh, yeah.
But we did try and, set people up with different things afterwards. And, we actually had quite a lot of aftercare and a lot of thought, and we're kind of still thinking about ways that we can do that. So we're very aware, I guess, of the kind of, yes, Mark, he picked that guy up for me. Great.
Thank you.
We're very,
I was thinking, apart from the ethical implications of not doing a crossover, I was wondering scientifically, did you really compare psilocybin versus escitalopram, or did you compare disappointing people versus not disappointing people?
I mean, I think, when you really, the further you go, but the thing is that, people did have good responses on the other side. I mean, the other thing is that often there was a whole context of the study and all of this care and love. And, in that sense, we also kind of didn't really compare an SSRI in the way that it's normally used either. So, I think it's complicated. I think research in mental health is incredibly complicated. And there's lots of arguments. But I think you're right. I mean, most people came because they wanted psychedelics. People didn't come saying, I don't mind what I get. If it's an SSRI, it's fine too. People really want the psilocybin. It's
kind of a one further proof that I'm unlucky in my life and things will always go wrong.
It brought up all kinds of feelings of rejection, of disappointment. It was really difficult. And I suppose it was very hard, and inevitably you kind of ended up sort of giving those people a bit of therapy because you felt, well, at least let's work with these feelings, and that was our guilt, I guess. But we're not probably good at research and better at being clinicians.
Right, it's understandable.
Yeah.
All right, so let's look for some more questions. Do you see any that you like particularly?
Good question. How do you know you're measuring trust and not a projection of what a patient thinks, and not a projection of what a patient thinks the skill level of therapist is? In other words, do we trust a skilled person more than an unskilled person? Then those appearances and all the biases, can you correct for those? Yeah, I mean, I'm not sure if I completely understand exactly what that question is saying, but I think it's something around, where do we start to think about how skilled a therapist is compared to, so I think you're right. I think it's really complicated. And I think this is an issue for any kind of therapy. I think that is why I think people who, the more skilled and the more experienced, the better. And because I think then you can more easily differentiate between what have you done that is maybe a little bit thoughtless or insensitive and made people feel unsafe versus what is their own projection. And that's kind of why, people need to do their own work, and why people need to really, I think, I can speak about my current training. I have to be in analysis 3 times a week. And I think the idea of that is to really be so aware of what I'm bringing into the room. So yeah, I think it's impossible to pick apart.
I think that's a great question. Sometimes there is this sentiment, or at least I hear it a lot from people who are sometimes, especially people who are skeptical of therapy schools or of particular therapy schools. A lot of people say psychotherapy, it doesn't matter what you do. What matters is just the relationship, right? But yeah, how do you build a relationship if you're just doing random stuff? So of course, I think it's a great question. I think it's always going to be a reflection of the quality of the therapy that you're doing. So it's hard to disentangle the therapeutic relationship from the therapeutic work, of course.
Yeah. And I think, I think what, when anybody who trains as a therapist, what you realize is like, you will always let someone down or do, you're never going to be perfect, but it's just how you deal with that, so it's just whether or not, when someone's angry with you, if you allow it and you talk about it and you treat it as something to be curious about and to think about, as opposed to you sort of rejecting it or being defensive, So I think, it's okay to do things that are wrong, or whatever, but I think it's just how you manage it. The same as, any relationship, I guess.
Yeah. I'm seeing a comment or a question by Gerd Gründer. It's another, actually he's the PI from our study. So I might read this. The disappointment after discovering that a patient was not getting psilocybin might have impacted the outcome. The possibility to get Verum after 6 weeks might prevent that. Yeah.
What's Verum?
Verum, it's the opposite of a placebo, I guess. So it's the real thing.
Yeah. I think you're probably right. I think, maybe that would have been much better. That if people kind of thought they would get it eventually. I can't answer, I wasn't there when we designed the trial, and it was already so designed when I came in. So I'm not sure why they didn't do a crossover trial. It would have been a lot easier for me if we had. But yeah, I think that's a really good point. I do think there was, massive disappointment for people, and of course that did impact on results. But people did actually still respond quite well, and this is kind of what makes me think actually that the relationship and the care, is really quite important. I mean, I suppose there's sort of this idea of like that if you feel loved, that might be all you need, so I do think people on the SSRI side responded really well, considering they were people who didn't, typically respond to SSRIs, who didn't want to take any more SSRIs, who wanted psilocybin. And what most of them would say was that it was the love and care they received. So I think it's true. I think it's a really interesting question.
Mm-hmm. Right. Here's a very practical question. I like these. What can a therapist do if a patient becomes paranoid?
Yeah, I think that's a really good question. I suppose sort of if you're I mean, what we would try, I mean, I guess it's sort of this kind of idea of like, okay, do you manage and try and make things a bit better, or do you try and sort of like plunge people in and go like in and through? And I think in theory, you try and work with it, you try and see it as, you know, a manifestation of not feeling safe, of social anxiety, of, you know, a projection. But I think the reality of when somebody is acutely paranoid, for me and for where I am in my own stage of training, is that you probably just try and help them to feel safe and sort of, you know, work with it a little bit. But I mean, I don't have experience, that never happened to us. And I think, you know, when I had one person get a little bit paranoid, um, I didn't really know how to help them go into it and how to work with it. And so she kind of had kind of awareness of the fact that she was being a bit paranoid. And so, you know, we were able to talk about it, but it was mainly just me reassuring her, you know, letting her know that she was safe, you know, and that kind of worked, you know, but I don't really know, you know, we didn't really have that experience, thankfully.
Mm.
But I guess in theory, Stan Groff would have just made it bigger, gone into it, worked with it, you know, but I'm not Stan Groff. So
No, you're not.
you may have noticed I'm not Stan Groff.
Yeah. Here's another interesting, that's something we haven't addressed actually. I wanted to address it, the topic of the therapist diet. So usually we have two therapists in psychedelic therapy. Here's Sasha asking, are there two therapists giving the therapy in your study? And if so, are there any complications in developing trust with a patient when it's two therapists instead of one?
Yeah. So what we sort of, in theory, what we tried to have was a man and a woman in the room. And I suppose there's this idea of, you know, that most of us, but not all of us, have grown up with maybe a male and female parent. And we have sort of different experiences of men and women. And so I suppose it's that idea of it being sort of like a reparenting, and also a chance for people to work through issues in each. You know, for some people, they might have had really bad experience with men. It was extremely healing to have sort of a caring, kind man in the room with them. But sometimes we had two women just because we ended up having a very female heavy team. We would have a main guide and kind of a co-guide, and the main guide would be sort of the main person working with them. So it wasn't sort of, I suppose, a 50-50 relationship. I wouldn't say there were any particular complications in developing trust. I guess sometimes people might have felt a bit more under the microscope, or as if they were sort of being scrutinized when there's two people looking at them. And occasionally you would see that they might have certain projections towards one person and feel safe with the other person. And, you know, sometimes that was as simple as, you know, you look like this person who I don't like, and you look like this person who I like, or, you know, this kind of thing. But I think from our point of view, we started off having one in the room, and honestly, it was exhausting. Like 8 hours, high dose session. You're basically afraid to go to the bathroom. And I think, you know, if you want to really be present and kind, you also need to take care of yourself. And that means not doing too many sessions in a week, and also maybe having that kind of movement of, you know, that you can have a bit of support, you know, and sometimes it's really difficult in the room and you're not quite sure what to do. We're all kind of new in some ways to this kind of way of working. And so I think, you know, people got a better experience when there was two of us.
Yeah. Yeah, thanks for this great answer. Let's look at, I think today may be the first time that we actually managed to answer all questions. So this one is probably easy. This is a yes or no question from Andreas. Did you choose the music, or did the participants bring their own music?
Oh yeah. So basically we had a playlist, and we would sort of check if they really hated any kind of music. So a few people said they didn't really want anything chakra-y or kind of, you know, new agey, that kind of thing. We didn't know too much of that, but, you know, if they were really adverse to it, you know, they really didn't want a kind of that kind of thing. And then we asked people to, you know, include kind of a couple or three of their own songs, and we would kind of embed them into the playlist depending on, you know, why they felt important or what kind of music they were and that kind of thing. Normally towards the end, and that was often quite a nice thing for people to hear their favorite songs towards the end of the day.
Yeah, I suppose when you've heard a song a lot of times, it can be a kind of a new kind of, as if you're listening for the first time.
Yeah, exactly.
Mm.
And people often picked things that had emotional resonance or importance for them.
Mm-hmm.
Yeah.
Right. So one more question. Last question. I've heard a prominent scientist say, don't remember who it was for sure. That's a good way, by the way, to start to start a question. I should do that in the future. That patients that feel very unsafe may see more of an effect with MDMA. What are your thoughts on that? So different places in the process ask for a different substance. That was the idea.
Yeah, I would totally agree with that. I mean, I think I was talking to Michelle, one of the therapists that worked on the team with the other day, and we were talking about actually that a low dose of psilocybin can, in a way, have that same kind of heart-opening sort of effect that MDMA can. So I think for people that that don't feel safe, definitely something like a low dose with psilocybin or something like MDMA might be. I mean, I'm not sure if your question was specific to MDMA or compared to psilocybin, but I think there is something about when you try and. I don't think it's a good idea to hammer through people's defenses. I think it's good to slowly unpeel the onion. So I think when people feel really unsafe, go slow. Don't try and kind of take a sledgehammer to the door.
Now people are asking more questions, but I think we can take those too.
I can answer this quickly.
They're quick. Yeah.
So about the comorbidity, we basically, pretty much it was just a depression trial. So we wanted to compare oranges with oranges. So pretty much most comorbidities were excluded. And emotionally unstable personality disorder was specifically excluded in our protocol, and the same with PTSD. And the reasons for that were that we just didn't think it was safe or fair to bring people in. And the PTSD in particular, I think, you have to be so careful with kind of bringing that kind of trauma out. And our protocol wasn't made for PTSD. It was a depression protocol. So we did exclude both of those. And the same with schizophrenia, bipolar. Anxiety was okay. But I think when you start bringing in comorbidities, it muddies the results. When will the results of the psilocybin trial be available and where? I don't know exactly when, but it will be in the New England Journal of Medicine. And I'm sure if you follow Robin on Twitter or David Nutt, they will be posting it there. So, yeah.
Yeah, I think everybody's really, really, really excited. We can't wait to read those results. And I'm sure if it's true what you said and the results look good, that it will give another boost of interest to psychedelic research for sure.
Yeah, absolutely.
Well, I guess now it's time to say thanks to everyone in the audience for attending. Thank you for the great questions. I think I really have to point this out that we always have great questions with our audience here. So thank you very much for that. Thank you, Andy, for holding the things together in the background, for doing a fantastic job at cross-referencing papers and interesting links in the chat. And of course, thank you, Roberta, for this very insightful conversation. It's been a big pleasure and in fact, very helpful for my own work as well. Yeah. And I hope to have you back someday. Would you agree to come back one day?
Absolutely. Yeah, it's been really enjoyable.
Yeah, thank you very much. Roberta,
for sure.
Do you have any closing remarks?
Oh, no.
Great. That's a good answer. Well, so before saying goodbye, I'd like to say that there will be more Zooming In webinars in October and November. We haven't fixed the dates yet, so we'll keep you posted.